Bismillahirrahmanirrahim. Now, taking the series upon the infection and the disease or infectiology, this is the largest chapter of the medicine, largest topic, because you know that the disease process which is going in our body, it may occur because of the inflammation, whether caused by a microbiological agent, caused by a trauma, or caused by an autoimmune disease, whatever the cause may be. Start as this, inflaming the specific tissues, and then it spreads. So the 70% of the inflammation, which is definitely a pathological process, and in some ways is a defensive mechanism of the body, comprises the infection and causing the disease. And I have taken about 9 to 10 tutorials for the basic terminologies of the diseases. And we are actually stressed previously upon that the classification of these microbiological agents should be known to everybody. Whether you are a house officer or you are a whatever you are, at this stage you should know. Third year, fourth year, final year. Myself, at the age of about 67, and a senior examiner of the CPSP examiner, as a FCPS medicine, or supervisor of many of them, or the guideliner of the many of the practicing physicians. So I am Professor S. Adi Hazar, and I was taking the what we call as the gram-positive cocci first of all, and then the gram-negative cocci. We give then after the chance to have a talk about the gram-positive bacilli and the gram-negative bacilli, then going for the further microbiological agents like mycoplasmas, like rickettsis, like coccidias, and like, for example, the very important organisms nowadays they are, and because people do not know much about it, that is the Schirmarius. And then going further with the parasites, and then the fungi. Maybe there will be a mixed type of the microbiological infection, it is possible. But you have to justify it anyway. So today I want to talk something about this Streptococcus pneumoniae, although I have already taken the pneumonia. Pneumonia, when I was talking on the pulmonology. But this aspect of the disease, for example, you have been given a case, a long case in which you have said that it is pneumonia, then you are opened the discussion to the examiner. The second part of the long case will be only of this pneumonia and the differential diagnosis. Because you are talking about the pneumonia, the commonest cause of the community-acquired pneumonia in your country and other countries as well is typical pneumonia, and the cause of the typical pneumonia community-acquired is Streptococcus pneumoniae. So I will talk something more about this organism, microbiology, that the Streptococcus pneumoniae or pneumococcus is a gram-positive. It is spherical bacteria. It is alpha hemolytic. under aerobic conditions. Alpha hemolytic and a beta hemolytic or the gamma hemolytic or beta hemolytic under anaerobic conditions, and aero-tolerant anaerobic member of the genus Streptococcus. Actually, it is a part of this Streptococcus, but we separate it because of the certain characteristics it has. They are usually found in pairs. That is why. Always in diplococci, that is called diplococci, and do not form spores. They are non-spawn spore-forming streptococci, and they are also non-motile. They have no flagellates and then no other cilia type of things on their surface. As a significant human pathogenetic bacterium, Streptococcus pneumoniae was recognized as a major cause of pneumonia in 19th century and is the subject of many humoral immunity studies nowadays. The studies has been going on and going on about the humoral immunity, that is acquired immunity, humoral immunity, and you can definitely take advantage of this research to combat this infection. To combat this infection, there are certain programs which are going on as vaccination is concerned. You developed acquired immunity in the person. Because why pneumococcal pneumonia, which is the commonest pneumonia, causing the global pneumonia, is a very important mortality in the geographical areas, and it is the main killing weapon of inflaming the lung in the very early age and other stages of the life, and in the old stage, old ones. More than 60 years are the risk factors. Less than the 1 year is risk factor again. Because the immunity developed in the neonate is actually lacking here, about 1 year, 2 years under. And the organism is very notorious. It is very, very, you can say, penetrative type of organism it is. It provokes inflammation, and it comes in stages. And this is the diplococci, found 2. And you see this is a crystal violet staining. It is gram-positive. It is not red. It is purple, it means gram-negative. Habitat, where it forms, where it occurs, it is a natural place. Streptococcus pneumoniae resides asymptomatically in the healthy carriers, typically colonizing the respiratory tract. Means from the nose, for example, in the throat, for example, in the ears, external air. Here they will act as the commensals, including the nasal cavity. However, in susceptible individuals with a weaker immune system, such as elderly person or young children, the bacterium may become pathogenic. If it is penetrate, and it will leave that site and spread to the other location to cause the disease. So you are living with this Streptococcus pneumoniae. It means that if your immunity are declining, it will take its chance to go to the other side and can infect that part where it becomes pathogenic there. So it spreads by the direct person-to-person contact via respiratory droplets. So mode of spread is droplet infection, and by auto-inoculation, a person carrying the bacteria in the respiratory tract. How an auto-inoculation? The nasal secretions sucked by a person, or the secretion which are collected in the throat or in the mouth, engulfed by the person, or by chance it will go into the trachea. It can be the cause of the neonatal infection. That is an important one, because in the pneumonae period, you are handling the neonate. Where it is commensal all on the skin, no problem. It enters the upper respiratory tract, it can go to the lower respiratory tract, and it can cause the inflammation in the lungs. How will you culture it? Now, Streptococcus pneumoniae can be differentiated from the viridans, because another infection is viridans. Streptococcus viridans can also cause the inflammation of the lung, but in a different ways. Now, some of which are also alpha hemolytic using the oxygen test. As Streptococcus pneumoniae is oxygen sensitive, you will introduce oxygen. It is sensitive, can also be distinguished based on its sensitivity by lysis by bile, and it can be engulfed by the bile, so called the bile solubility test. In this way, it is separated from the viridans, which is not oxygen sensitive. Both are alpha hemolytic, no doubt, definitely. But oxygen sensitive is Streptococcus pneumoniae, while Streptococcus viridans is not oxygen sensitive. In this way you can separate it. Another way to separate from this in the culture media is introduction of the bile. The bile will engulf this culture, while Streptococcus viridans will remaining there. Another important morphological features of this organism is they are encapsulated. Encapsulated, it is gram-positive coccoid bacteria have a distinctive morphology on the ground stain. It is lens-shaped diplococci, as previously described in my slide. This one. You can see that these are there. They are arranging in two twins, making here the chains, this fashion. And you see in the light microscope, it will see just like a lens. A lens. They have a polysaccharide capsule that acts as a virulence factor. This capsule is polysaccharide. The capsulated organisms are virulent organisms, always remember. Whether they are Haemophilus, whether meningococcus, whether they are pneumococci. Virulent factor is polysaccharide. And it can only be checked by the spleen. If you are removing the spleen, remember, then you are opening the subject to the three capsulated organisms which are very dangerous. Gram-negative Haemophilus influenzae and gram-positive pneumococci and gram-negative gram-negative cocci, that is meningococci. You are actually giving chance to develop this infection that is called superated infection in these persons. Before the splenectomy, you have to give vaccination against the three organisms. This is a very common question asked by the examiners, whether it is final year or whether it is FCPS Part 2 examination. What we will do before the splenectomy? Triple vaccine should be given. This is the answer. They have a polysaccharide capsule that acts as a virulent factor for organism, more than 100 different. As serotypes are concerned, it is research, epidemiology is concerned. Serotypes are 100, more than that. And these types differ in virulence, and external drug resistance. In different geographical areas, different serotypes are present. Associated disease with Streptococcus pneumonia is the main cause of the community-acquired pneumonia, typical pneumonia. and it can cause meningitis in children and the elderly also. And of sepsis, means that you are going for the bacteremia, and then you go for septicemia, and then SIRS and pymia, and going for this sepsis, septic shock, and so on. This has become very aggressive in immunodeficient patient, that is in HIV. The organism also causes many types of the pneumococcal infection other than pneumonia. What are these diseases? Bronchitis, acute bronchitis, rhinitis, acute sinusitis, acute otitis media, conjunctivitis. It can cause definitely in children meningitis, sepsis, osteomyelitis, and that is important in children. Again, septic arthritis, infectious arthritis, endocarditis, peritonitis, pericarditis, cellulitis, and brain abscess. So in the cases of the spreading infection in the form of the pymia, it can locate in these specific areas which are mentioned. So it is a multi-organ dysfunction syndrome, MODS. In the end, if you will not check out, primarily it will spread like a wildfire. The pathogenicity is considered of pneumonia is a part of the normal parasitic flora. It is commensal. It will give the chance if the immune system is suppressed to invade invasions such as the pneumolysine. It has pneumolysine, an antiphagocytic capsule, polysaccharide capsule, various adhesins it has, and immunogenic cell wall components. They attract the chemotatic reaction are all major virulent factors. After stroke pneumonia colonizes the air sacs of the lungs, alveoli, the body responds by stimulating the inflammatory response, causing the plasma, blood, and white blood cells to fill the alveoli. Main oxygen and carbon dioxide exchange takes place in these places. Respiratory alveoli. This condition is called pneumonia. Actually, pneumonia is the condition in which the inflammatory exudate fill these spaces. After filling these sacs, it is the hardening of the organ now, and this is called the consolidation. The lab diagnosis is generally made on the clinical suspicion along with a positive culture from sample from the virtually any place in the body. Whether you are going culture from the bronchoalveolar lavage or sputum or from the pleural fluid, from the blood, etc. Streptococcus in general, it is oxygen sensitive organism. Although in some geographical areas, oxygen resistance has been observed. In the majority of the cases, it is oxygen sensitive. Or bile, if you put bile, it will engulf the colonies. We are confirming it. The recent advances in next generation sequencing and comparative genomics have enabled the development of the robust and the reliable molecular method for detection and identification of pneumonia. You can go for PCR of anything, for example, in the sputum or for the pleural fluid. And the Zixo gene was recently described as a biomarker PCR basic with detection of pneumonia and differentiation of closely related species. Now, this gene was described as a biomarker. What is biomarker of this? Is Zixo gene. Now, it can be detected in the urine by what is called as a pneumococcal antigen. Can be detected from the urine also, because it is called antigen present on the cell wall, detaches it, and you can detect it by a kit in the urine, and you can label it the person to have this Streptococcus pneumoniae. Atromycin and the decomilonon possesses the antibacterial activity inhibiting the enzyme phenyl carrier protein reductase, essential for the biosynthesis of fatty acids in the Streptococcus pneumoniae. So it will also be used as to separate these colonies from the other colonies by microbiologists. The atromycin and it is inhibiting this enzyme, and it is essential for the biosynthesis of fatty acid, which is essential for the Streptococcus pneumoniae to maintain the cell wall. So you can separate it also by this means. The management. Now here it comes that antibiotics are the mainstay of the treatment of Streptococcus pneumoniae infections. Until 1970, essentially all pneumococcal isolates were sensitive to easily achievable levels of the most commonly used antibiotics. It is gram-positive cocci sensitive to the beta-lactams. Cheapest are the penicillins, including penicillins and the macrolides, the clindamycin, cephalosporin, rifampicin, vancomycin, timoxepril, sulfamethoxazole, that is cotrimazole or Ceftriaxone. Beginning in 1990s, many pneumococcal isolates in the United States showed decreased susceptibility to penicillin, that is benzyl penicillin or penicillin G, and other commonly used antibiotics. That is why they have established that the clavulanic acid should be added to the broad-spectrum synthetic penicillin, that is amoxicillin. The amoxicillin with the clavulanic acid is very, very important tool for the management is concerned. The primary penicillins are now resistant. The primary cephalosporins, the primary clindamycin and primary sulfonamides, they are resistant in certain geographical areas of the country. In 1974, when I was in first year 74-75, and I was in third year in 1977-78, my teacher, Professor Ghaffar said that the neglected antibiotic which are using by over-the-counter in the pharmacy these are sulfonamides. And at that time, these Ceftriaxone suspension tablets are available at the cigarette and pawn shops even. So he said that it is very, very good drug against the pneumococci, against the salmonella in children. They are well tolerated by the children. At one time, cotrimazole was given in the initial stages of the pneumonitis or pneumonia caused by the Streptococcus pneumoniae. But nowadays, because of the people use in the wrong way, wrong dosage, wrong time, for the least duration, the resistance developed against these very important, very, very cost-effective antibiotics. You have to use now the clavulanic acid with amoxicillin, or you go for the higher cephalosporin, third generation, or you go for the carbapenems, azotenams, fancy medicine, very, very costly medicines. You go for the vancomycins, you go for the fusidic acids, difficult to, it is not available very easily. Or you can give now the third generation cephalosporins, the quinolones, fluoroquinolones, and nowadays, at least there are the macrolides, the third generation again. The azithromycin is the drug which has called evolution in the management of this problem. So then CDC actually checking is this. In our country there is nothing like CDC. Most powerful, unit is CDC in America, but I will say it is the most powerful, very honest people. They are very hardworking. They do not know about anything, any command given by anybody. including the President of America. They don't bother to listen. Whatever they say, they will say. After 10,000, 20,000, 30,000, 1 million population studies based, they will declare this drug is safe, is effective, you can use it by prescription, how much, etc. They said this is the combination of amoxicillin with chloronic acid, the first drug of choice in most of the geographical areas of the world. First drug of choice it is. Remember, do not use the other drugs. They say if the patient comes with this Streptococcus pneumoniae, you hit directly the erythronyms. No. You have to first use this drug, see the response clinically. Or you go for the culture and see the culture and sensitivity. That's all. The resistance actually developing because of our fault and because of the country management fault. Here, the drug inspectors in your country, they are taking the bribes. They do not visit the medical stores. Even the medical store, pharmacy, they are not qualified. They do not know about the Zetro tablet and Zentro. What is the difference between Zentro? Zentro, is a trade name of Zentro. It is the pantoprazole. And Zetro is the trade name of a very important drug, is the azithromycin. They don't know about it. If you are not really writing the prescription, I used to write in the capital, Zentro, 40 milligram, 20 milligram. Or I will write it like this, Zetro, Zetro. It means that I am using the azithromycin. Try to remember that if you are writing these type of drugs, please bracket it with the generic name. It's better. What drug what is the dose, how much it will be taken, and in which duration. Before the means, after the means. Now, resistant pneumococcal strains are called the penicillin-resistant pneumococcal, penicillin-resistant Streptococcus pneumoniae, PRCP. Again, another variety which is called the Streptococcus pneumoniae, penicillin-resistant SPPR, or drug-resistant Streptococcus pneumoniae. These are the terminologies which are using by these epidemiologists. In 2015, in the United States and in North America, there were an estimated of 30,000 cases, and in 30% of them, the strains were resistant 30% to one or more antibiotics. It means that they are using the combination then afterwards, using the microlides with the amoxicillin chloronic acid, or you using the moxifloxacin with the third generation cephalosporins, the ceftriaxone for example, etc., etc. In this way you can manage these cases, because these are very dangerous situation in which we will use what is called the put score. When we are detecting the pneumonia, the score, if it is more than 110, the high mortality is there. 110, 115. So it means that the patient are prone to develop any type of complication. Vaccine has been developed, alhamdulillah, and it's a very effective vaccine against this type of pneumonia. Try to vaccinate the old people and in the month of September every year. And also in the child pneumococcal vaccination has been programmed in those areas where there is high pneumococcal infection. It is a separate vaccine program other than the routine EPI program. But in our country, it is not included in the EPI. You have to buy it and inject it. But in other countries, it is a part of it. In the United Kingdom, United States, South Africa, because they are advanced countries, we are not advanced. I will say we are rather very poor nation. We have to buy this vaccine and inject in our geriatric population specifically, and neonate, it is possible. At the age of 9 months or 10 months afterwards, where you are also vaccinating the child with the measles. Crossing parallel with the measles, you also inject the pneumococcal vaccine. So this is a brief discussion about the pneumococci. I want to clear it from every angle that it will cause a problem. It is a problematical organism. Do not take easily. Try to understand the pathogenic process, the clinical features, management, the complications, and the complications of the management, and the end results of this. Because these have all been discussed actually previously with, I was already taken in the, I talked I think about 3 months back with, where I was talking about the lung diseases, that is the, I have taken it as pneumonias and the different type of pneumonias, pneumatology at that time. So this is the actually revision of some part of it, but I am stressing on clinical microbiology. If you do, you should know about the clinical microbiology, some aspect of it, because you are open to the examiner. He can ask any question. Please try to remember it. If you are not successful in this examination, it means there are fault in yourself, not in the examiner. Please try to understand this point, because you have to know from every aspect. The disease should be known from A to Z. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.